Just a quick reminder, everybody, if you could please sign the registration piece of paper outside the door. We need you to sign for both days. So when you picked up your packet and your bag the first morning, we had everyone sign. We need you to sign, please, for today for your continuing education credits. And we've made it convenient. It's right outside the door. So let's jump into the next one with our esteemed Mary Coughlin. We're all big fans of hers, and she's going to talk to us for a shorter session right now on the perceptions of international neonatal teams, or the POINT project. Please welcome Mary Coughlin.
Okay, awesome. Okay. All right, well, hello, everybody. So the POINTS project is a really fun and big project that I'm really excited to share with you guys. The acronym, well, actually, so I have nothing to declare except my passion for trauma-informed care, I think that's okay to say. The POINTS project is an acronym, and it stands for Perceptions of International Neonatal Teams. And it's their perceptions regarding trauma-informed care. The etiology, of the traumatic experiences, understanding toxic stress impacts the baby, the family, and the clinician. Also, we gather information about the degree to which staff feel supported in the work that they do in the NICU. And then there's a series of questions delineated by different sections, regarding staff perceptions across the physical environment, the emotional environment, and the practice environment in the newborn intensive care unit. So this project got kicked off through the encouragement of a dear colleague of mine, Amy DeGata. I don't know if you guys remember Amy was one of our presenters at a past Science and Soul conference. Amy's a nurse researcher out of the University of Rhode Island, and super passionate about this idea of trauma-informed care and toxic stress and early life adversity. And I shared with her that I've been collecting surveys, I've been collecting data from the clinicians that I've been working with over the past several years. But I wasn't really sure what to do with all the data, besides the obvious, when I worked with a particular unit, the purpose of the survey was to collect baseline perceptions of where the staff felt they were with regard to their knowledge of toxic stress and all those items that I just shared with you. And then I would repeat the survey to just follow the progress in their improvement. There were many folks that participated in the survey, though, that didn't want those follow-up surveys to be repeated. So I just had this really big body of data. And so she suggested that maybe we look at it. Maybe this data would give us some information. Is there a global gap with regards to understanding the impact of toxic stress and early life adversity? Was there a global gap on staff perceptions about the practices specific to developmentally supportive care? And so I said, okay, sure, let's do this. And when I started looking at the data, I have like over 1,000 data sets. So I'm going to just show you an average, like a kind of a aggregate of the survey, and just, hopefully get some feedback from you guys on what you think, okay? All right, cool. I got to put my glasses back on. All right. So these were the particular areas geographically. The United Kingdom, specifically Scotland and England. In the United States, I have samples from the Midwest, the Northwest, the West Coast, the south of the U.S., and the Southeast. And then in Canada, we have a pretty good cohort from French-speaking provinces and the English-speaking provinces. So again, I just aggregated all of these responses in the results that I'm going to share with you. So these are the different sections of the survey. I collected information about the demographics with regard to their location, what particular unit. I mean, one of my bigger visions is to take this idea of trauma-informed care in the NICU outside of the NICU. There's a lot of really great research now being done in the PICU, in the pediatric ICU with regards to trauma-informed care, pediatric emergency rooms, and that sort of thing. So I really see, this concept transcending all patient populations. But for the purposes of what I was doing, I was trying to delineate, are you in the NICU, PICU, transport, and that sort of thing. I also got information about what your discipline was. And so I collected soup to nuts, whatever discipline, is out there on the planet. I asked if you were part of that team. And I can just tell you, with regards to the demographics, I think I shared just a little bit of data, but needless to say, the largest demographic respondent to the survey was nurses, because nurses, of course, make up the largest number of healthcare professionals. So most of these results are from nurses' perceptions. And then, of course, I told you about the other supervision, support, the physical, emotional, and human environment. And then, just to give you a little background, so I didn't make this survey up myself. There's an existing trauma-informed care survey that has been validated. It's used in the behavioral health world. So I took that survey and adapted it for the newborn intensive care environment. And so actually the practice environment section of the survey, those are all my questions. But the reason why I'm explaining this, besides the fact that I should tell you it's an adapted tool, is because they included the perceptions of the staff with regard to how well their organization's policies, procedures, guidelines aligned with the values and the principles of trauma-informed care. Okay? So these are, okay, I didn't realize I had already put a slide in for here. So these were, your primary role, your unit, years of service to newborns, and years of service at your current employer. And then I'm going to jump right into the knowledge and the support. And this was really interesting because I've not looked at it this way before preparing for this talk, so it was really interesting to me. This is at baseline, without any folks receiving any formal education with regard to early life adversity, toxic stress, in the neonatal intensive care unit. You can see that the scores are all below 3, and my scale was a Likert scale of 1 to 5, with 1 being never, or we don't get any education, and 5 being, oh yeah, we're rocking it. We're all over this topic. So for me, this is pretty significant. It's really showing me that there is, at least within the groups that I collected data, a significant knowledge gap. If it's 1 to 5. You okay with me saying that? Okay. With regards to staff supervision, it was a very similar response pattern. I think it might have been the Canadians that were answering in the higher range, in the 3.37, 3.17 range. But in general, there's not a lot of support. And I did, I left it in my bag, but I did want to just explain to you what some of the questions were, so you have some context of what are they answering about. And it was really about the degree to which the unit supports the staff in doing the difficult work that they do. So are there structured, scheduled exchanges with the staff, with your supervisor and your direct report, where you're talking about how they're doing with their job, how are they handling the stress, do they need any support, any resources. It also asked questions about formal debriefings after a critical event. So for example, after a demise or some type of a really acute critical event, is there a set process where staff are afforded the time to step away and debrief about the situation? That was very uncommon, at least in the staff perceptions. That's the other piece of this survey, is for the perception piece. When I work with a unit, I actually go in and then try and validate this, right? Because you may perceive that we don't have a policy, for example, for pain management, but maybe you actually do, you just don't know it. So, validating the perceptions is an important piece of this. But for the purposes of examining my raw data, I really just wanted to understand what people thought about the things that were happening in their unit. Does this surprise you? Do you guys feel like you get a lot of support or supervision in your clinical environment regarding critical events or traumatic experiences? I mean, in general, in my experiences, there's not a lot of formalized processes. There may be informal processes. Am I explaining this okay? All right, just want to make sure. And then, if you remember in the previous slide, I then broke out the questions into physical environment, emotional environment, and practice environment. In the physical environment, the aspects that I was looking at was, kind of the standard light, sound environment, but also smells, the olfactory environment, the gustatory environment, how frequently do we provide positive oral experiences. Again, framing these questions based on the definition of the environment per the core measures. So in the core measures, the environment is comprised of the physical environment, the human environment, and then the organizational environment. So those aspects were evaluated in this line of questions. And so by and large, it's pretty neutral. Most folks feel, yeah, we're okay, we're in the middle. And I'll tell you in a little while, well, that's why that's not the goal. But it's still good information, right? So, and the other thing, though, that I thought was so striking about this data, I'm afraid to hit the light button, but okay, is look at how evenly distributed these are. But these are across, Canada, the US, and the UK, and various different regions within those environments, but it's pretty fairly distributed. Obviously, it would be really interested to look at this in a larger group, right? In other European countries and other countries across the world. But I thought that this was really, really interesting that they were so evenly dispersed. Same thing with the emotional environment as well. And again, people are pretty much in the middle of the road. The higher end of the threes, which was really nice. And the questions around this were really looking at to the degree to which the infant received relationship-based encounters, how frequently the clinicians were actually engaging with the patient, talking with the patient, but not just the patient, also the family, to the degree to which the family was a partner in the care. There was a series of questions in this section also that looked at, there's some really great papers that are talking about involving families at that organizational level with quality improvement work. And so, those types of questions were involved in here as well. So really shifting from that paternalistic kind of traditional view of an emotional environment to really an integrated emotional space. So really interesting here as well, I thought. Now the practice environment, hold on. I think I can just do this. The practice environment, that's basically everything else, and that's when I'm looking at your pain practices, your bathing practices, your facilitating eating experiences, postural support practices, all of those other practices that are, disease independent, but part of the holistic care of the patient. They basically made up the difference of all of the remainder of the core measure criteria. And again, you can see, again, across many countries, it's pretty evenly distributed. So on first pass, looking at this, I thought, so everybody's pretty average, right? Because I'm thinking, 1 to 5, you're in the threes, the 3 to 4 range, you're pretty average. But I'm kind of a stickler about this sort of thing. Because if I know 5 is always, and these are evidence-based best practices, in my mind, our patients should be getting the best practice always, not just usually. But as I say that, I know that that's common across a lot of other different practice parameters. So I found that this was really interesting, and I'm looking forward to doing more detailed analysis and comparison, working with Amy on this tool. Because the other thing I should tell you, first of all, if you'd like to look at the tool, you just have to email me, all right? And I will share it with you. It's on SurveyMonkey. It's really easy, and you might think you want to do it, but then when you do it, you'll realize it's about 10 pages, and there's about 60 indicators that I'm asking people to participate in. Now, it's great because I get a lot of great information, but it's not very user-friendly. So the other part of this project that I'm working with Amy and a few other colleagues with is to see if we can improve the usability of this tool. So we've done a myriad of factor analyses with the tool to try and see, can we bring down that number of indicators to something a little bit more reasonable and user-friendly, that the unit could actually take that tool and assess the quality, or the degree to which they align with a trauma-informed approach in their environment. So stay tuned. Okay, so there you go. And then this was the piece, as I had mentioned, that our very last question, we're asking clinicians the degree to which they feel that their organization provides safety within the context of their policies, procedures, and guidelines. So how well do you feel your policies, procedures, and guidelines speak to the safety needs, emotional and physical needs of the patients and the families that they serve? Same thing with trustworthiness and choice. And I mean, again, it's a little bit higher, which was nice, but these are also fairly intangible concepts. How are you going to prove to me the degree to which you believe that your policies and procedures really align with safety, trustworthiness, choice, and collaboration? And so, another piece of this journey, and we are certainly looking for folks that might be interested in working on this, is how do we define that? How do we quantify these aspects of, these principles? How do we quantify that they are being operationalized at that patient interface or in the organization? You doing okay? This is the worst speaking spot, right? After everyone's eaten and you all got a full tummy and all the blood in your brain is shunted down into your gut. And I've just got a few fragments, a few cells are like, is she still talking? Yes. Yes, she's still talking. So the other piece that I wanted to share with you, though, oops, fudge, hold on. So this was really interesting, though, as I mentioned at the beginning, right? My goal, for having people fill out this survey is that you're gonna do another one, because I want to see, is there going to be an interval improvement? And for a variety of different reasons, folks don't always opt in. They want to find out where their baseline is, and then they want to work on it, kind of a DIY, do-it-yourself improvement. Absolutely fine, But there are two organizations in particular that have opted in to do that benchmarking and have embraced and committed to a journey to become a trauma-informed organization or trauma-informed facility. And so while I was collecting this data, I thought, okay, here's my chance, right, to see. I've got some more data points. Is there an improvement? This graph here only represents the aspect of the knowledge. Because both of these organizations are working on different core measures, I thought that it would make my talk too long. Yes, it would make my talk too long if I made all the comparisons. But this really made my heart sing. So both of these two organizations are pursuing trauma-informed care designation. And with regards to their knowledge, which was both over, one was over a 6-month period of time, the other was over a 9-month interval, they have a statistically significant improvement in the staff perceptions, all right, of the understanding of toxic stress and its implications for the infant, the family, and the clinician. But it's also corroborated with pre and post testing. So I know that they have more knowledge. The thing that was interesting, though, is that the second data set was collected well after, so the pre and post test was right around the education, right? I just bookended the education. There's no guarantee that that knowledge is sustained, but at least staff perceive that they have a better handle, a better understanding on the implications of toxic stress and early life adversity in the patients that they're serving. Okay? So now I'm going to ask you guys, any questions about this? Yes, ma'am? share a link with you if you wanted to collect some baseline information, you know? There's no obligation that you have to do anything with it. Exactly. And
They leave the hospital and go somewhere else, and there should
Exactly.
be little support for them.
And I like the question because what you're pointing to is, you know, you recognize that there's a problem, but oftentimes we struggle to get support to address a problem when we can't quantify what the problem is.
And we don't get enough support from the management.
Mm-hmm.
Yeah.
So I think this, and particularly one of the hospitals is a US-based hospital. We also looked at their staff satisfaction and staff engagement survey data as well, because that's a big piece of what motivates executives in the US to, you know, invest in their staff, is when it affects their ratings across these, you know, important metrics that they've identified. So, yeah, I think it's good to get a quantifiable idea of where folks are at and how folks feel.
Okay.
Yeah,
Thank
so,
you.
yeah, just shoot me an email, okay? Any other, yes, ma'am? Oh, I'm sorry, microphone.
Particularly with the knowledge domain, but also perhaps with sort of the regularity of some of the practice environment. Do you think the baseline measure is ever overestimated by staff, and that they feel they have more knowledge than in actuality they probably do about some of these concepts?
Yeah, I mean, there's always that chance, right? Because it's a perception survey, which is why it's so important when I go on site that I do audit what it is that these indicators are representing as best as you know, I'm able to, and then make the comparison.
And in doing that, are there areas that you find are more often overestimated in perception than in others?
So what's interesting is people seem, and this is my perception, all right, but it seems like people are more judgmental on themselves the first time they see the survey. Oh, no, I take that back. They're not. They're actually more generous the first time they do the survey. Thank you. And then when I repeat it, then it's like, oh, now we know what she's talking about, and they're more judgmental on themselves. So I don't see as much of an improvement. And then that makes it even more fun to then repeat it again. So that you're right. On first pass, people, because they don't really know what it is that I'm talking about, if they really know nothing, it seems like it collates pretty readily. But if they have a little bit of knowledge, it gets a little bit gray. Yeah. I think that's with qualitative stuff in general, though, I think. Yes, ma'am?
So I was just going to ask, when you say that you're validating this, when you go back, is that qualitative data that you're pulling in?
So when I validate it, it's actually quantitative data.
Okay.
So I actually sit down and look at their policies and their procedures. I look at the EMR, at their documentation, look at, you know, what are all these other aspects. You know, I'll go in if it's light and sound, if it's the physical environment. I look at the space and do that, so that and corroborate it to each of my indicators.
Do you have qualitative measures in the survey itself?
It's just a Likert scale,
It's just
so
a
I
so
feel it's a
all
perception.
quantitative.
Yeah,
Okay.
it's all perceptions.
Okay.
Yeah.
Okay.
Yeah, no, thanks. And so this project really, does anyone have another comment or question? Yes, no, Mike, okay. Really brings me to the project that I had introduced to the folks at the pre-conference. I'm working with a really amazing interdisciplinary international group of clinicians, and we've created a certification around trauma-informed care. It's a unique approach to certification. Our approach is that while standard certifications are really grounded in knowledge, so if you're the smartest person in the room, you pass the test and you get the extra alphabet, you get the extra initials. But similar to like the way the NIDCAP does, the NIDCAP, it's, you know, that's great that you're really smart, but we need to see you demonstrate that you're actually competent in doing this. And so we've tried to use that type of a model. The certification is not attached to any specific program, because we also know there are many paths to becoming trauma-informed care. I don't hold the keys to the kingdom. There's lots of different ways. And so the way we've created it is so that it will be recognized by the International Credentialing Excellence Organization, so that it is a, you know, sanctioned official certification. But there is a knowledge component, but then the participant, or the applicant rather, is invited to then submit exemplars of how they demonstrate their competency across the 8 attributes of a trauma-informed professional. I don't have a slide for this, so I'm just going to list them for you. So the 8 attributes are: one, it's knowledgeable, that you have a healing intention, that you practice personal wholeness, that you are courageous, that you are an advocate, you demonstrate advocacy, your role model or mentor, scholarship, and then you exemplify a leadership skills for change. And we've got different aspects, that you have to put in there to, prove to the faculty, prove to the board that you are indeed meeting these. You also need to have 2 letters of recommendation, one from a colleague within your discipline and one from a colleague outside your discipline. Again, because it takes a village kind of work. It's not just about having all your friends endorse you. I mean, of course, if you have interdisciplinary friends, maybe. But they also have to be able to provide some exemplars. So we've tried to create something that will really build a tribe of leaders for change. Everyone starts at the novice level. That's the other piece of this certification, is we've created a matrix of mastery. You level up with each recertification. The initial level where everybody comes in is novice. That's just bare bones. And then you're demonstrating your competence as a trauma-informed professional at that individual level. When you level up, then we're inviting you to be a leader at the unit level, then at the organizational level, then in the national and international level. So that we really have, competent, qualified, courageous people that are mentoring other folks in really transforming the experience of care and really adopting a trauma-informed approach. So that's it. Any questions, guys? Was there? Oh, yes, ma'am. I think somebody might want to mic you. Question? Oh, right behind you, hon. Yep.
Thank you for the invitation to join the tribe and grow the tribe. I'm very interested in our unit becoming a trauma-informed care center. We're a premier unit in this Pacific Northwest, and I don't think that we are at all in the circle of trauma-informed care. We are close to it. We do a lot, but we're not fully in that circle. And I want to bring it there.
Sure.
And I want to know, because there are always barriers, the units that you've been involved with, what were their barriers? What barriers did they have to break down in order for this to happen? For them to, the people in Aberdeen, what barriers did they have, and other hospitals that you've been involved with?
To begin the journey, and I can actually, I'm just trying to be mindful of the time for the research forum, but generally it's engaging stakeholders, key stakeholders, to really buy in and see the relevance of this in your unit, and particularly for your patients and families. And then other barriers can be financial barriers. The methodology is pretty straightforward. It's adopting the IHI, the Institute for Healthcare Improvements methodology for cultural transformation. And then, of course, a lot of knowledge, addressing all of the knowledge gaps. But maybe what we can do, when are you heading out?
Tuesday.
Maybe I can hook you guys up. Do you guys want to hook up? All right. So let's all meet back at the place. Yes. Yes. I don't know what you're saying. Does that sound okay? That sounds great. All right. Awesome sauce. And I'm going to hold the questions there. You can meet me up after the conference back at the hotel, or email me if you have any other questions that you'd like to get some answers to. All right? Sound good? Without further ado, I'm going to turn it over to Christy, who's going to introduce the faculty for the research forum, which will be the next segment, and then Mel and I will close out the conference for you. Okay? Oh, you're so good. How about a quick up and down? Everybody stand up. Yeah, I can feel, it's warm. Jazz hands. They can. I was going to talk about that at the end. Yes. Okay, deep breath in. Bend back. Oh! Blow it out all the way down. Touch your toes. There you go. Okay, sit down.
Wonderful. Thank you, Mary. So I was just informed that the next speakers want to come up together. So I'm going to introduce all of them at one time. And we're going to start with Maria Alice Santos Corrado. Professor Corrado has her master's in child development, PhD in human kinetics, and a degree in statistics and management. She is a specialist and professor in pediatrics methodology of research. Her passion is research in neonatology. She works in creating the partnership with the students at SL, and the neonatal intensive care units. She is also affiliated with Unit of Research and the SL, and coordinator of research and innovation and development in practices in neonatology. Please welcome Maria Alice Santos Corrado. And to join her, we have Teresa Vasconcelos. Teresa is the manager of the Neonatal Intensive Care Unit of Hospital de San Francisco. How'd I do? I've been practicing. She is moving into new roles as the nursing director of the hospital. Her specialization is in pediatrics and clinical research in WITH, the Unit of Research and the school. So we're having the first speaker, Professor Corrado, is going to speak on evidence-based practices, family-centered care in the NICU. And then Teresa Vasconcelos is going to talk about Kangaroo Care in the NICU, a parental discussion. And I'm just going to move to the next topic, parental experiences, parents' response to stress in the NICU, which is going to be presented by Fatima Maria Calaro Sosa. Fatima is a registered nurse in the Neonatal Intensive Care Unit at the Hospital de Santa Maria and master's student at AZEL, who will graduate in May. We're really glad you're here. And the next speaker is Nisa Rubina Soto. Nisa's topic is parenting in neonatology, an educational promoter of intervention of health literacy. Nisa is a specialist in rehabilitation and works as a registered nurse in the Neonatal Intensive Care Hospital at Madeira. She is a PhD student at AZEL, who is also translating the Quantum Care for Parents app into Portuguese. Please welcome these ladies. We're glad to have them.
Good afternoon. Thank you for coming. Boa tarde a todos os colegas e a todas as colegas, aos estudantes da ESL. Obrigado muito especial por terem colaborado connosco neste evento. Thank you, Mary, for accepting our invitation for third annual Congress on Trauma, Informed Care, Neuroprotective Care, taking place in Lisbon at ESL. We are very proud of your presence and all colleagues, scientists, researchers, and health professionals and educators who come from United States of America, Portugal, Qatar, Australia, Belgium, Scotland, Germany, Italy, UK, Israel, and India to participate in this Congress. I hope you felt at home and pleasant with the contribution of this Congress. Thank you all for your presence. I'm going to speak about a larger project, innovation and development practices in neonatology that's supported by neuroprotective core measures. But the research forum is focused on one of the measures, family-centered collaborative care in NICU. The goals of the major project are to qualify and develop the nursing practice and the discipline of nursing through innovation, research and training, to promote effective evidence-based health care to transform the culture of care, to improve short and long-term positive outcomes for newborns and families, to health professionals in NICU, to hospital administration, and the health organization that are supported by quality indicators of the Portuguese Ordem dos Enfermeiros, the Nursing Regulator Association. The methodology is partnership as well with the NICU of Lisbon and Funchal, because NISA work in Funchal, Madeira Island. And in developing the research project, innovation, and developing the practice in neonatology. We work with students and nurses, focusing on students' education and reflections on nursing care and evidence-based practice. This preceptorship in which the teacher, the nurse, and the student have moments of work together to promote the development of research projects. We use different theories in nursing. Here we have Florence to represent all the nurses that you read and you use in our projects. Brazelton is a reference for us in Portugal. ALS, for us and for everybody, I think. And Mary Phillips, but for us, Mary Coughlin. Okay? We used to, in this project, a theory to walk with all the projects. So we begin with secondary research, identifying and mapping scales and nursing interventions using protocol of Joanna Briggs Institute, promoting evidence synthesis, evidence generation, evidence transfer, and implementation of research outcomes in practice, with a major object, the global health of newborn and families. We are focused on evidence transfer and implementation because they are not always easy. It's a big difficult for us. This major project began with Teresa Vasconcelos in 2009, and translating and statistical validating the early feeding seals assessment scale. And we continue with other research projects supported by neuroprotective core measures, but it's difficult to implement anything in the units. You don't believe that. You believe, I think, because probably you have problems too, like we have. In this research forum, we are going to display the results of three studies that show the importance of collaborative care with families in NICU, because we heard every time that we are doing the things very well, but we think that we have much more to do. It's my opinion. In conclusion, we hope those projects will contribute to improve quality, innovation, and change in practice of care. This partnership in research contribute to nursing education, continuing professional development and increasing research in health and evidence-based practices, and also promote research skill development, including communication, the results through a variety of channels. Nursing records on IT system could be improved by using reliably and valid indicators of health in neonatal care and influence health policies. The major contribution is the promotion of parents' literacy and their empowerment through informed decisions. Note that health literacy is very low in Portugal, and we have to know what happened with our parents in the NICU. I finished this larger borders talking about something that you can say that's a case of success. This is the translation and validation of neonatal skin risk assessment scale. We publish an article after the translation. We present the results to the Direção-Geral da Saúde, a dependence of Health Ministry, and to the Ordem dos Enfermeiros, the Nursing Regulator Association. This work was recognized, and currently the scale is integrated in the S-Clinic and BSimple computer system to be used in many NICU, not in all of them in Portugal, but in a lot of them, by health professionals in assessment of the risk of skin injury. At the moment, we have a case of success because we are finalizing the guidelines for skin injury prevention and intervention in newborn in Direção-Geral da Saúde, which will be officially applied in all neonatology units nationwide. Let me introduce the forum. To introduce this forum, Mary, let me appropriate your words. Like Mary Coughlin and all of you in this auditorium, I think, we believe that parental presence, emotional well-being, and confidence and competence in parenting comprise the attributes of family collaborative care core measures that are fundamental to recovery, the hospitalized infant, and the integrity of the family in crisis. We need NICU that advertise 24 hours and restricted access to families. We need NICU with professionals with welcome attitudes, and we need NICU with organizations committed to family-centered collaborative care. And to continue, Teresa, Fatima, and Nisa, they are going to display some results of 3 studies, and each of these studies report to the 3 components of family-centered care, collaborative care. Parents are integral to the comprehensive care of their hospitalized infants. Assessing and supporting the emotional well-being of parents is an express priority. Competence and confidence is parenting skill, mentored, supported, and validated over the hospital stay. Thanks Teresa, Fatima, and Nisa. Your work is the example of a very good partnership involving different health professionals. Without all the professionals and students that you are representing in this forum, all the work developed would be impossible. So, thank you very much. And Mary, thank you very much because you are an inspiration. Thanks again for your support, for learning, for searching knowledge, and reflecting on the evidence-based practice in neonatology. Teresa.
Good afternoon. So we have spoken in this Congress about Kangaroo Care a lot of times, but nothing is enough because Kangaroo Care is a global care for all the neonates and families. So in 2017, we analyzed the data and we saw that we had, I don't know for sure, but more, I think about 70% or 75% of the babies were doing kangaroo care, but in the final of the hospitalization, less than 50% give up the kangaroo care and change to holding in arms. So we wanted to know why, because if Kangaroo Care is so important, why the parents let to do the kangaroo care during the hospitalization and at home. So kangaroo care, or skin-to-skin contact, is the holding of a diaper-clad infant on the parent's bare chest to maintain for not less than 30 minutes in order to yield physiologic benefits for the premature infant and to give them time to adapt position and changes with enough recovery time. Kangaroo care should last as long as it is supportive to both infant and parent. Could be minutes or hours, so it doesn't matter. The importance is important for both. Why we believe in kangaroo care? Because children and families are vulnerable, and we have spoken in this Congress also. Because they are susceptible to being wounded or harmed. They have the possibility of being struck by a physical illness. They have the possibility of fragility, and they are unable to protect their own interests. There are lots of benefits for mothers, and these are ones. Mothers who initiate, and we know for the research, kangaroo care in breastfeeding within 30 minutes decrease rates of postpartum hemorrhage. The release of oxytocin helps to promote bonding and attachment, and these mothers demonstrate lower scores on scale for depression and lower salivary cortisol levels. And Thomas Kuhn shown with this research. Kangaroo care promotes their self-image and health. There are also benefits for the fathers because improved initial bonding and attachment, there are more involvement in care of their infant and a greater perception of the infant needs. Fathers gain a higher sensitivity to the newborn in a positive way and to be more physiologically available to their infant. Benefits for full term also, that's why we have to invest more on kangaroo care. Because there are physiologic benefits, and you know what they are. Decreases cortisol levels, indicating a decreased stress response after birth. Prevents hypoglycemia, stability of bilirubin, improved thermal regulation and blood glucose regulation, enhances neurologic, motor, and mental development. Kangaroo care also helps the infant to be colonized with their mother's bacteria, helping regulate the infant microbiome and decreasing colonization of pathologic bacteria such as MRSA, Staphylococcus aureus. So this is a great task because in each year we have every more difficult germs, and it's more difficult to deal with them. Premature baby have these all benefits, and we know that enhances maturation, promotes growth, reduces pain, enhances the frequency of deep sleep episodes. So the goals of this research was identification of the parents' knowledge of kangaroo care, analyzing the parents' opinion around the benefits to the infant and to themselves, and identification the necessity to change the positive touch method during the hospitalization. The design of the research was exploratory with a qualitative approach. The data collection was a semi-structured interview. All the parents that had experience of kangaroo care and other types of positive touch during the hospitalization, and the inclusion criteria was parents that have done kangaroo care and holding in arms. The population was, we got 21 interviews, 14 of mothers and 7 of parents. From the content analysis of the interviews, there emerged 6,995 occurrence of words, distributed in 809 forms. This diagram shows the behavior of the words in the corpus. The vertical axis representing the position of the word frequencies in descending order, and the horizontal axis, the frequencies of the forms, but shown in logarithmic scale. So, through descending hierarchical classification, 200 textual segments were analyzed with a retention of 63.5% of the corpus for the construction of the clusters, which gave origin to 4 classes from the partitions of the content of the interviews. This table shows the classes and respective lexicographic analysis. I tried to translate well, I hope you understand. The classes are the reasons for giving up of kangaroo care, the parents' feelings when they participated in kangaroo care, the parents' information regarding kangaroo care, and the benefits of kangaroo care for parents and babies. This dendrogram shows the 4 classes from the content analysis partitions. So for the class 1, the words, the principal words were reasons for living, use, closes, day, and finish. So, the interview excerpts that show us the reasons for giving up the kangaroo care in this first class allow us to contextualize the reasons that underlie the parents' decision to stop using kangaroo care, which is responsible for 19.7% of the text segments analyzed with the textual corpus. Next, we refer to the significant levels of words, starting with the word association with a p less than 0.001, such as reasons for not using kangaroo care. The other association refers to the words taking, close, day, and handing with a p equal to 0.004. All of them show the reasons of the origin of the parents' decision to stop using kangaroo care with their children during hospitalization, as we can see in these phrases. I try to translate. Sometimes it's not easy because they speak differently that we write, but here there's some, the M is a mother and the P is a father when you see. The reasons for leaving kangaroo care, I think, we started to hear the nurse saying that we could hand kangaroo care and make holding in hands. I put these phrases here because we have to think what we sometimes influence parents to not continue something that is marvelous and has a lot of benefits. The other, we stopped using kangaroo care because she grew and it was more difficult. Instead, we started doing more holding in arms. The other, the day I put on clothes to the baby, it became more impractical because I then needed to take both mine and his clothes. Some of the phrases show that parents are concerned about the comfort and well-being of the baby. And reasons to stop using kangaroo care, I felt the need more when S moved to the cradle and then handed kangaroo care. The second class, parents' feelings when using kangaroo care, this represents 19.7% of the analyzed text data and shows us the feeling of parents' participation in kangaroo care. The words baby, belly, important, born, and mother emerged associated with a p less than 0.001 and denote the importance, according to the mothers, of feeling that the baby was theirs once again. The words sensation and son or daughter represent an association with a lower level of significance, 0.0004, but also highly relevant. For these mothers, it felt as if their child was reborn, thus allowing them to reassume their maternal role. Their words, as can be seen in the following excerpts, and are related to the feeling of loss and recovered of parenthood. This was a father, a moment of intimacy with our son, which was immensely moving and comforting. Kangaroo Care First is the first time we had physical contact with our baby, and it was priceless. When mothers have a normal birth, as was the case with my first daughter, it is a wonderful moment when the baby is placed on the belly. This time I didn't have the same opportunity, but Kangaroo Care still gave me the magical sensation. It is hard to explain. It's a feeling of love, connectivity. It felt as we were still one person and that she hadn't left my body. And another one, this phrase, it was the first skin-to-skin contact, the first touch we had with our daughter, with our baby. I think it was something important and very moving. The third class, parents' understanding of Kangaroo Care, represents 29.9% of the analyzed text data and show us how the parents were informed about Kangaroo Care. By whom and how. The words nurse, speaking, poster, contact, unit, and knowing emerged associated with a P less than 0.001 with a lower level of significance equal to 0.001. There also emerged two words of no less significance, explained and understand. These represent the importance of the information given to the parents. The following phrases are an example of that. So, our first contact with Kangaroo Care was through the nurse. She spoke about skin-to-skin contact and asked if we heard about it. We also saw an information poster about Kangaroo Care in the unit facilities. The first contact I had with Kangaroo Care was through the poster at the entrance of the unit, which asks if you have ever experienced Kangaroo Care. I was really curious about the method when I realized that it was the technique of putting the baby skin to skin. It's wonderful. I really enjoy use it. The nurse who spoke to us explained everything. So you can see that nurses and the poster, that is a small poster, and I'm going to show you as the most important things for their start to using Kangaroo Care. I first learned about Kangaroo Care through the poster, then I start to see some mothers using. When I saw this, I asked when I could start. I was told it wouldn't be possible whilst my belly button catheter was in, because sometimes the babies are not comfortable to skin to skin with this belly through the mother's belly. But once that was removed, I could commence. As soon as the nurse removed the catheter, I request to start Kangaroo Care. And this is the small poster. And ask, I like to do Kangaroo Care in Neonatal unit. Have you done yet? Ask how to do it. So it's simple. And we never thought that was so important for parents. The fourth class, benefits which Kangaroo Care represents for the diet. 30.7% of the analyzed text data show us from the perspective of the parents the benefits for the diet. The words to feel and calm are associated with a p equal to 0.001, and the words to feel the body 0.006 and stay 0.008 emerged independently regardless of any association. Also, there emerged a new association of the words hand and grab with a p equal to 0.002. The following phrases are an example of the benefits. So we have, I don't gonna read everything because they are big, but you can see that is very important, and they know the benefits of kangaroo care in relation to the diet. The similarity analysis summarized the highlighted classes in which the terms kangaroo care, to be, contact, nurse, benefits, to feel and give up, determine the parent's perception of the use of kangaroo care. This is originally is a French program, but we find it in Portuguese, but we didn't find it in English, so I can put this in English. But I put in this left side the principal words, and you see does it works? Okay. We see the kangaroo care, to be, feel, let, give up or let, contact, and benefits. So this highlighted how the baby is reacting positively, stay calm, quiet, peaceful, and we can see that sensorial contact gives the parents pleasurable sensation to feel and smell of the body with skin-to-skin contact. And also those responsible for providing information on kangaroo care, the poster and the nurses. It also emerged that the benefits of kangaroo care contribute to the physiologic stability of the baby and the sensations related with kangaroo care, positives and negatives, and why parents stop to use kangaroo care. So I'd like to ask you 2 questions for finishing this presentation. And what year we are? 2020. What is that year important for us nurses? So, I show these results. We know all the benefits of kangaroo care. Why we don't work more when the parents want to leave the kangaroo care, pretending that it's uncomfortable for the babies, and why we don't reinforce and empower the parents to do more kangaroo care. I think it's a real task, and as you say in this Congress, baby steps are more important. It's a challenge for me and my unit. And to finish, we all want these pictures. This was a baby who did kangaroo care in our unit, and now is how she is. Thank you.
Whoops.
Now I think it's okay to start. Good afternoon, everyone. First of all, I would like to thank the invitation. Thank you. Thank you, Alice. And I'd like to thank you all to listen to me about some results from the translation, validation, and adaptation of the Neonatal Parental Stress Scale by Tilly Reid for the Portuguese population. So let's start. Let's rock. The problem that sustains this study emerged from the reflective practice that is performed daily as a caregiver of high-risk newborns and their parents, and the experiences lived by parents in NICU, and the influence that they may have in their child's development and parenthood. We all know that the admission of a newborn to the NICU can be a source of stress for parents who face a multitude of stressful experiences due to the aggressive environment and the fragility of the newborn, but also due to the perception they developed in relation to their inability to take care of the child, to protect him. The inconsistency of care practices is also one of the most common complaints among parents, and the one that most negatively influences their satisfaction, interfering in the construction of trusting relationships and family-centered care, inhibiting the maximization of health and the transition to positive parenting. Knowing that parents play a decisive role in the newborn's development and in his future, and that they need support to understand their role and challenges, it is necessary that nurses develop interventions that promote the transition to positive parenting. So, identifying and validating the instruments for assessing parental stress and stressors and assessing their psychometric qualities facilitates interventions and informed decision making by health professionals. Sorry, I lost myself. Não, não encontro aqui o rato aqui. Sorry. The technical and scientific knowledge evolution in neonatology provide the survival of premature babies and others with very severe pathology, although some face a variety of sequelae that could influence their development in long term. Along with this progress, research on neonatal epigenetics referred that the adverse conditions adverse conditions early in life, pre and postnatal, and the quality of environment that is experienced can affect and alter the epigenome, expanding the vulnerability of newborns in relation to their development in the future. If bad experiences become repetitive, they can cause changes in the epigenome. Although it is general knowledge that children can survive without their families, it is essential to optimize the child-family relationship, since the cognitive, physical, and emotional development will only occur in a context of love and positive interaction with caregivers emotionally involved that have the potential to promote health and well-being of the child. The increase in scientific knowledge made it possible to recognize the newborn as a singular individual who needs interventions that promote his development. As a consequence, nursing care has also evolved in order to respond to these needs. These approaches to assessing and promoting the development of newborns consider their individuality, favor interaction with parents, and their integration in care, and can have an impact on how they perceive their babies. Thus, by better understanding their baby's behavior and messages, parents respond to their needs, which favor bonding and attachment, promoting development. As you can see, all models recognize that parents play a key role in their family neurodevelopment. So it is crucial that nurses develop family-centered interventions to reduce parental stress and promote positive experience in NICU. As I mentioned earlier, the admission of a newborn to the NICU can be a source of stress for parents who face a multitude of stressful experiences. Parental stress is an adverse psychological reaction which arises before the demands of being a mother or a father and is experienced with negative feelings about oneself and the child. Parents have feelings of anxiety, loss of control over what is happening, guilt, depression, fear about the survival of the baby, and changes in the parental role with postponement of the bonding process. Parental stress can last between 8 weeks to 2 years after delivery and have a negatively impact on family relationships, the relation with partner and bonding, and attachment with the baby. One of the interventions of health professionals consists on recognizing the needs of parents and developing consistent and adequate care in order to assess and reduce parental stress. That's why parental stress has been studied by several researchers who develop models and instruments that assess parental stress in NICU. Nursing interventions should be guided by principles supported by research and its results because, like Qualitative says, nursing research is about real people with real problems, and studies of those problems offer opportunities to address them through improvements in healthcare nursing. So, the interest phenomena must be translated into data and subject to analysis using instruments that facilitates the assessment of the person's responses and needs, enhancing best practices. In the first phase of the investigation, pre-validation study, we intend to assess the significance of the different predictors of parental stress in NICU using a multiple linear regression model that allows to identify among the measured variables, they are gestational age, birth weight and parents' age, those that have a significant influence on the dimensions of parental stress. This is an analytical, observational, and cross-sectional study with a quantitative approach. The sampling is non-random, casual of newborn parents, with a dimension of 172 observations. First, we made a formal request to the author, Tilly Reed, to use NUPS. Then we asked permission to the Ethics and Data Protection Commission of 7 public and private NICUs. The translation process of NUPS was based on the recommendation of the cross-cultural adaptation health-related quality of life measure that gave rise to ESPUN, Escala de Avaliação do Stress Parental na Unidade Neonatal. Com licença. ESPUN is an ordinal scale with 5 points, has 65 items distributed over 4 dimensions: sights and sounds, appearance and behavior of the infant and treatment, relationships with infant and alterations of the parental role, practical hassles and social relationships. Data collection for validation of ESPUN started in July 2019 and is still ongoing. The estimation of the psychometric sensitivity of ESPUN was assessed using skewness and kurtosis coefficients. The absolute values of skewness were below 3 and 7, and their critical ratios under 2. The reliability of ESPUN factors was estimated based on the internal consistency of the items in the 4 dimension using a alpha Cronbach, considering an acceptable reference value 0.7. As we can verify, Cronbach's alpha value for the global and each dimension are greater than 0.8. In the first phase of the study, we intend to assess the significance of the different predictors on the dimensions of parental stress using multiple linear regression model that allow identify among the measured variables, predictors, those that have a significant influence on the dimensions of parental stress. Data analyses were performed using SPSS. The predictors were, as I said before, gestational age, baby birth, weight, and parents' age. Of the study participants, 108 were female and 64 male. The average age of the parents is 33 years. The gestational age of the newborn admitted to the NICU varies between 24 and 41 weeks. And the minimum birth weight was 520 grams, and the maximum weight was 4,250 grams. It was verified in this study that items show psychometric sensitivity proved to be statistically significant for the dimensions appearance and behavior of infant and treatment, relationship with infant and alteration on parental role, and practical hassles and social relationship. But it was not being statistically significant for the dimension sights and sounds. Of the three predictors considered, parents' age, gestational birth, and birth weight, only the parents' age and the gestational age are significant predictors of the appearance and behavior of infant and treatment dimension. The predictor of parents' age is the only one statistically significant concerns the social and family relation dimension. What are the implications for practices? All nurses should base their clinical decision-making on scientific evidence, their experience and practice, and in the therapeutic relationship with the person care. Guided by principles, supported by research and by results. Nursing research is about real people with real problems, and studies of those problems offer opportunities to address them through improvement in healthcare nursing, using instruments that facilitate the assessment of the person's responses and needs. The identification and selection of an instrument to assess parental stress experienced in the NICU and the study of the significant predictors for the parental stress make it possible to implement practices based on family-centered care and collaborative care, assessing and supporting the emotional well-being of parents. I thank you all. See you next.
Okay. It's with gratitude that I am participating in this amazing event with the purpose to share with you the PhD study that I have been developing about parenting in neonatology and educational promotional intervention of health literacy. Mary, I will definitely write this opportunity in my diary, my gratitude diary today, as you mentioned yesterday. As we all know, the adoption of these attributes and criteria of family collaborative care, parents are integral to the comprehensive care of their hospitalized infants, assessing and supporting the emotional well-being of parents is an express priority. And 3, competence and confidence in parenting skills is mentored, supported, and validated over the hospital stay are the major core measure of this work. This last attribute is the foundation of my research. It focuses about parents' education and empowerment. To meet this goal, parents need to understand the information given to them. What the evidence shows is that to have an effective educational intervention in the units, we must consider the knowledge about prematurity, motivation, and also parents' health literacy. And parents' health literacy, it's the ability to access, understand, evaluate, and communicate information that enables parents to engage in child care and make decisions for their health. Studies about health literacy in the NICU are still scarce. I found 3 only in the USA. But these studies have revealed that parental high literacy levels in the NICU are still low and are common peaks when the professionals are discussing with parents about complications. But these parents may establish an adequate communication with health professionals during the NICU stay if they have low levels of health literacy. And they also have poor compliance with instructions affecting the acquisition of parental competence. But in the other hand, parents' health literacy increases during the NICU stay. So we can assume that NICU experience can influence health literacy, which is good. However, it remains unclear how health literacy has been promoted and considered in the parenting process in this context to foster a family collaborative care. So, with this in mind, we conducted a scoping review intended to map interventions with the potential to promote parents' health literacy in the neonatal units. And the results were based, we consider intervention that targets at least one of the 5 factors that are affecting health literacy outcomes integrated in this model, the health literacy intervention model. This is proposed by Gibbers et al. We have five factors. We have the community support factor, the empowerment persons with low health literacy, communication parents and professionals, health literacy capacities from the professionals, and reduction access barriers. We only found in this this review, the analysis of the results showed that interventions have focused primarily in factors that empowers person with low levels of high literacy, like NICU parents, and interventions to promote community support, and thirdly, factors that strengthen the parental health communication. Interventions aimed at enhancing professional health literacy skills, as well as improving communication and access to health systems, were not identified. These two ones, the two that doesn't have the heart, were not identified in this scoping review. But we can assume that may reveal that the evolution of the health literacy concepts and the need, and also the need to do some research about this phenomenon. The important intervention identified were educational programs like Train to Home, like Hug Your Baby or COPE program, written material like NICU diary, and more recently, recently, audiovisual material was used to empower parents, like audio recording, websites, videos, and apps. One of the included studies was app systematic review conducted in Canada, and which is identified 18 apps available for parents in the NICU. The Qualitative Care for Parents had the highest overall quality mobile application rating scale score and received a high score on perceived impact on parental knowledge, attitudes, and behavioral change. So, congratulations, Mary. And considering that mHealth apps provide a new way of delivering health information. And we also know that have been considered a resource in promoting person-centered healthcare, especially for people with low levels of health literacy, like parents in the NICU. So there is a need to conduct more studies in an effort to develop evidence-based educational interventions that can contribute to promote parents' health literacy in the NICU setting with the resource of mHealth technology. We conducted a study intended to evaluate the feasibility and educational intervention aiming to promote parents' health literacy in neonatal unit settings with Portuguese Quantum Care for Parents app as a mHealth resource. This study design includes 4 phases. First, the translation of the app to Portuguese. Second, the parents' needs. We need to know what are the parents' needs by doing exploratory study. And this translation, the study to translate the Plot 8, that is an instrument to evaluate health literacy of parents of infants until 1 year of age. It's the only instrument, not newest vital signs, and it's not specific for parents with infants with this age. Okay. The first phase was the translation of Quantum Care for Parents. We are now in the pilot test stage, so it's almost, I see the light. So finally, because it has been 2 years, yes, during this process, because it's an app. It includes technology, so it's a little more challenging. Okay, and we believe that the Portuguese version app will be available to Portuguese parents and could be an educational tool for us in the NICU. The second phase, it aims to analyze the parents' needs regarding educational health interventions at the NICU, and also identify those they consider more appropriate. Now we are in the data analysis stage. We have done focus group, parents who stay in the NICU only 50 days, and parents who are longer, okay? These hearts these hearts that are here, it's because I can tell you that what parents more value was the heart-to-heart connection they have in the NICU. Okay. The phase 3 will be the translation and cultural adaptation of parental health literacy activities test, like I said, and it's also in the experts phase. Okay. And at last, will be the final study will be the evaluation of parents' health literacy using the measurement instrument validated in the previous study. So we will evaluate parents' level of health literacy at the beginning and at the end, and we'll have 2 interventions. One educational intervention with the mHealth resource, the app, and other without the traditional educational process. And I finished this presentation hoping that this study can contribute to create a more family collaborative care in the NICU.
Thank you very much, ladies. That was awesome. Nice work. Okay, that leads us to our next presentation. We'll have Mary Coughlin again and Mel McIntyre. And they're going to talk to you a little bit more about from inspiration to activism. Where do we go from here? Please welcome Mel and Mary.
Sure, yeah. Well, first, yes. Yes. Oh, yes. I think that's a really good idea. I think let's just get energized, okay, before we start the wrap-up. Does that sound okay? So go ahead and put your stuff down. Everybody stand up.
Can we turn the lights up for this presentation, please? Keep them bright. Thank you.
Yes, thank you. All right. Yes, we can leave them on. Yes, absolutely. All right. How about we just swing our hands without hurting our partner? Just swing your arms. Lift up your legs. Raise your arms. This is my favorite one. Jazz hands, yeah. Nice deep breath. In through your nose, out through your mouth. In. Woo! I want to hear it. Come on. And. Woo! Isn't that lovely, huh? All right, guys. All right. Go ahead and have a seat. We really wanted to put, if we could leave the lights on, that would be great, please. If we can leave the lights up. We really wanted to, bring this conference full circle, right? And so this is the reason why we entitled this section From Inspiration to Activism. We hope that yes, good, yeah. We hope that you are feeling really inspired by all the amazing speakers, all the amazing information that has been shared over the past 2 days, and I'm feeling like wicked excited. That's a Bostonism. Wicked excited about the future of nursing. Having all of these amazing nursing leaders present their research and their commitment to improving the experience of the patients that they're going to serve Very, very exciting. Florence is smiling down on all of us right now. But of course, the action piece is just as critical, right? It's great to get inspired, but if you don't do anything with it, right? Not such a big deal. So it's really, really important that we come full circle to what how Mel and I opened up the conference and talking about what your greatest ambition is for the legacy that you want to leave the world. Pull out your notes. No? No notes?
So as you look back at your legacy, what we want you to do is just to reflect on how that may have evolved over the last 2 days. And just take a moment to do that, please. And if you didn't manage to come up with something yesterday, then maybe now there is something. Something's been sparked within you. There's something that you've been inspired by. And what we're not going to do in this session is give you any more content. Yay! But what we are going to do is take you through a process where you're going to be able to review and evaluate your learning in a nice, simple, easy way. And we're just going to ask you to share some of that collectively and as a community. So just take a moment to review that ambition that you had. So who is feeling courageous enough to share what their legacy or ambition is? What's been evolving for them over the last couple of days? Go for it.
Wait.
Oh.
Let's get the microphone. Hold on. Wait for the microphone.
Mine hasn't changed. Been a bit thought-provoking. So it was to be kind, to have made a difference, and to be present.
Amazing. Wonderful. So over the last 24 hours, how have you measured up against that? How kind have you been? How present have you been? And what was the other one?
And to make a difference.
Make a difference, okay.
I think we could all be kinder. I think we can all be kinder to ourselves. I think that's the one we miss out a lot on, and I think that's been touched on. I think.
So how have you measured up against that in the last 24 hours? I'm putting you under a wee bit of pressure, but that's all right.
That's all good. I think coming to this conference and having time to myself, I've been kind to myself.
Great. Well done.
So I feel I am reaching that goal a bit better, but I've still got a way to go. And I think you can always be kinder to other people. There's always ways that we can impact and be kind to other people. So there's still a bit of work to do there as well. I like to see it as a work in progress.
She wasn't kind to the cuttlefish.
No.
So if you could commit to one small action that could perhaps become a habit, which would enable you to become kinder, if that's your ambition, what might that be?
I think it's a bit like that self-care, isn't it? If I'm kinder to myself, then I've got more to give to others, and I think that will allow me to offer that kindness.
So I'm going to drill you down to a specific,
Yep.
right? So keep working down into what is that specific thing that you feel is the next best step for you to commit to regularly to have that self-care, to emulate that self-kindness.
I need to not feel guilty about taking time for myself and be kind to myself. And I think making sure that even on a monthly basis, if I take time for myself that is just for me, even in day-to-day stuff, not just big things like this, then that'll give me the headspace and the opportunity to share that and move that on with other people as well.
Amazing. So what are you going to do every month to be kind to yourself?
Come to Lisbon.
Yeah. Can I come?
I think the first thing will be just creating that time for myself and then deciding what I do with that time. The world could be my oyster.
Amazing, amazing. So does anybody here schedule time with themselves? Does anybody here make dates with themselves to do things just for you? 2 of us? 3 of us? 3 of us. Oh no, there's 4. The reason that I really drilled down on that, you get it, right? It's one thing to have a concept, and the tendency is to say, hypothetically, this is such a great idea. And I know that if I'm kinder to myself, I'm kinder to others, therefore it makes the world a better place. That won't change anything, right? That won't change anything. And almost you kind of kid yourself that you're doing something because you've thought about it. But that won't do the thing. You have to follow through on action. And the more you commit to yourself, and the more you make that a regular thing, and the more you create a habit of it, that's how you evolve your behavior. That's how you evolve who you are and how it feels to be you. So it's really important that you're able to operationalize the ideas that you've had over the last couple of days, right? That they don't just stay up here somewhere, that they don't just stay in your notebook, that you use them as rocket fuel to propel you into making 2020 the year that you really fulfilled the goals that you set for yourself. Not just for your NICU, not just for your tiny patients, as precious as they are, but for you. That's what it looks like in practice. You show up for yourself first. Right? So anybody else want to share their legacy? I'll get off my soapbox for just a moment. Sorry about that. Everyone's like, no way am I putting my hand up now. Susan, you're going to be brave there. Oh.
When you talked about being a nurse healer at the beginning, I thought about empowering others. But the way I did it on day 1 versus now, it was more of an empowering others with my goals versus empowering others to have goals.
Wow.
and so I did notice that I was a little more.
I love that. I saw that when the camera came. It was like.
Yeah.
That's fantastic. I love that. What a great example of really shifting your insight and awareness of the impact you can have through the way that you show up and lead. So that you're not there to tell people what their ambitions are. You're there to facilitate them understanding and connecting with their own ambition. Which one of those 2 strategies is more likely to be successful? 2, right? Absolutely. Absolutely. Thank you for that. So what we want to do is give you a few moments to review your learning experience, and then we're going to just get you to shout out some of your answers, okay? So we're going to really make this last part as interactive as possible. So there's some sentence starts for you here. And all we want you to do is take your notebook out and take a few moments to just fill in the blanks of the sentence, okay? So I was most surprised when that happened. What was your most memorable moment? When did you feel most inspired? When did you feel most connected? What did you wish you had been done? What did you love most, and what do you commit to doing differently? So we're just going to give you a few minutes to do that, okay? And then as I said, we'll get some conversation flowing. Mary just shared that she's excited that you're actually writing stuff down. Don't know if that's a sign of things about our presentations or what. Okay, so I appreciate some of you might need a bit longer, but that some of you are done. So now's a good time to start. So who wants to? In fact, Mary. I'm going to put Mary onto the spot. Mary, what surprised you most?
The thing that surprised me most was when my husband walked across the stage to the soundtrack of the Fat Boys and did an amazing breakdance over on the other side of the stage. That surprised me the most. I did not believe you. I did not believe you.
What were you most inspired by? She doesn't know I'm doing this.
Oh, gee whiz. No, not the breakdancing. I was most inspired by the nursing students. I was really touched by the work that they're doing and pursuing to really advance nursing care in the newborn intensive care unit. That's what I was most. Thanks for doing that.
Okay, so we're warmed up. You get the picture. So who wants to just any of that, like throw in your input? Go for it.
I felt most connected when Nicole was doing her presentation because every time she stands up and talks on behalf of our unit, I feel immensely proud of her.
How wonderful. Amazing.
That was also my most inspiring moment.
Oh, wow.
Nicole's talk.
Well done. Keep it coming. Keep it coming.
I was most inspired by the fact that people got up and English was not their mother tongue. And all of them did a fantastic job, and it's like not just were they conversating in English, they were doing a scientific presentation in English, and I was just totally amazed by that. And then that gets into the whole educational system in the United States and how we're not taught second languages and stuff. But it's just very inspiring because they're not similar language.
Yeah. Let's just. I have to agree. That's mine as well. Absolutely amazing.
I felt most connected during the silo busting activity. We had such great discussion in our group, and I was just touched by people from around the world having similar experiences and facing similar challenges.
Amazing. Wonderful. Thank you. Because we're more similar than we are different, right? And when we take the time to connect with that, everything becomes infinitely easier, including the way you care for the babies, right? We're more similar than different. The nurses who are resisting the change are still doing the best they can. The parents who are struggling, they're still doing the best we can. So I think that's a really meaningful point to make. Keep them coming.
Oh, good. Who's? No, I was excited somebody is taking the mic.
I was just going to say, one of the things that I loved the most was how welcoming everyone has been, how hospitable, and how they went to great lengths to show us some of their culture. I loved the students singing and their music presentation. I just loved, I felt like we got a glimpse into their culture and their country, so that was really meaningful to me.
It's such a rare opportunity, right, to be introduced to that side. I mean, when you come to scientific programs, obviously there's a heavy scientific aspect to it, which is the thing that I love about what we've created, that this is science and soul. And I know other conferences also strive to do that as well. But it just adds that extra depth, that connection that really makes it real and memorable.
And that was my most memorable moment.
Oh,
the
was it?
band.
Yeah.
Oh, I just honestly, it completely lit me up. I loved it, loved it, loved it.
I'm doing a combo. I felt most connected just by being here amongst people who are very like-minded and most inspired by our ability to come together and pursue trauma-informed care certification and doing a deeper dive and making being a part of a global movement, each being a component of that throughout this Congress and as everyone goes home and sprinkles it throughout the globe. I think that's pretty exciting.
Yeah.
Just kidding. Can I just say, and also to be able to be in the space and be vulnerable with one another, to really open up our ideas of actually what the action step is going to be, right?
I think that's probably what I loved most was when we had the Q&A yesterday, and just a lot of the discussion was the vulnerability that people shared. Where's my colleague Fatima, who shared this morning the pain that she's experiencing in caring for the patients. Linda, who shared her story yesterday. It just feels really special, you know, for people to feel that safe and connected with each other, to share that. We're all on the same journey, right? We're trying to do the same great work. It just was really the thing I love the most. Yes, ma'am.
I wish I had known this before. I came in here without any idea. I am not a NICU nurse. I am a lactation consultant, but visiting in NICU. I was just invited by my old friend. She's a NICU nurse, and we know each other, but she was like 8 years. We have not seen each other. And by Facebook, she said, "Come on, let's meet each other in Lisbon." Yeah, join me in Science and Soul.
That's awesome.
And then I was very proud asking my manager to give me a PTO that I have to go in Portugal for a conference. And they're saying, "What? You're not going with the ILCA, the International Lactation Consultant, but you're going to Science. So what is that?" Yeah, we never heard about that. I said, "Oh, it's great." And I said, "It's great." And
It is.
Yeah. Honestly, I'm touched, especially that I feel most connected when Dr. Sanders was talking about human or body language. That has been like the one most that shows best. Yeah, even it is different from what you speak, but
Yes.
your face. Because I remember myself going to NICU, helping mom to breastfeed, and I saw a little baby with nasogastric tube, and I said, "Oh my God, can she feed with that?" And oh no, I have to change my behavior. I have to change my body language. So I feel connected also with that. Thank you very much.
Thank you.
And thank you for my friend too. Yeah, memorable experience for me. Thank you.
So we'll see you next year, yes?
Well, can I say
That
something?
is such a great example of what we all need to do more of, right? Seize the moment, seize the opportunity, take courageous action, go for it, ask your manager, put yourself out there, and look what you've opened yourself up to. I think I really, honestly, truly applaud you for being here. Absolutely. Yeah, well done.
I felt most. Oh, please. For me, it was essential you to spoke about courage and about hope, because all the professionals, all the parents, and all the babies need to travel through the hospitalization, need courage and hope. And thank you, because you are so lucky to have some therapists, some psychological support, and sometimes you don't have, we in Portugal, and we struggle.
Well, we're here for you.
We are for sure. Yes.
Okay, last couple. Nicole? Okay, we'll come to you as well, yeah? Oh, you have the mic.
Okay. I was most surprised when me, as a nursing student, I could understand not all of them, but most of the speakers and most of the not conferences, but presentations that all of the speakers were presenting. And the majority and the principal meaning that I understood, so I feel kind of proud, and thank you all for that. And what I loved the most was how many doors this Congress opened to me as a nursing student and future, hopefully, nurse. So thank you.
Absolutely, yeah. We're very proud of you, too. Nicole? Oh, Leila.
I wish I had a home in Lisbon and find a guy and divorce my husband. I really like, how you guys welcome us, and I didn't feel like, I'm new to this place. Everybody was so friendly, and everybody, I talked to them. It was really a nice experience, and the speakers were very great. The food was great, and we went to the trip. It was really nice. I really enjoyed it. I'll come next year, too.
Yay!
I would add to that, the Portuguese hospitality, personality, beautiful women, beautiful Portuguese women. They're just so natural and easy and beautiful. I was here for the first time in August and September and was so thrilled to come back. And I have to say, coming from Qatar, the very inexpensive and very good Portuguese wine.
Oh, yes, yes, yes.
I wish I had remembered to say when I spoke that one of the most uplifting moments for me in my career was when I remembered that the person I was waiting for was me. And I just wanted to reiterate that to everybody in the room. Everybody tends to wait for somebody to come along and help them and do something. But the person you're actually waiting for is right here, it's right in front of you, and it's you. I just wanted to remind everybody.
Yes, of course.
Can I speak now? As a nursing student, as my colleague, I'm grateful for this experience. This is, I guess, an open eyes for everyone, because in Portugal, we still have lacks in our practice that we have to change. I didn't know I liked neonatology until a couple months ago. And now I'm very moved and touched for this,
It's okay.
Sorry, experience, yeah. And this area is very important for me. And I want to change something.
You will. Come on. Sharon, okay. Okay, we've got two. Microphone.
There should be two mics. We need one here, one here.
Uh-oh.
Sorry. Thanks to Mary for organizing such a great event, and I like so much that I want to take it to India. So I already told her, and we should have such a conference at India. And I don't know how much you know about India, but in this context, we are leading in preterm birth.
Yes, yes.
And there is a huge necessity of this concept, so that our generation next is safe. They are kind of a good optimal outcome after NICU stay, and at the same time that is going to decide the future of the nation and world, because if this protective care is going to help them to become good behaviorally, emotionally, cognitively, and definitely motorically.
Oh, thank you so much. Okay. Oh, Sharon? Last one, Sharon.
This will lighten it up a little bit. My most memorable moment was watching Mary Coughlin chase the bus.
Why did I miss that?
In my defense, okay. The bus was moving. The bus was moving, and I was not on the bus. I felt an urge to run after the bus. So, oh my gosh, you go next.
Okay. Okay. Did you enjoy that process? That was great, right? Just to hear everyone and have a chance to think that stuff through slightly differently. And so it's just to reiterate, and I won't keep drilling this point home because I think you get it. But if you stay in your comfort zone, it's going to get really uncomfortable. Because that's not why you're here. You're here to play a much bigger game than that. And that's why we're here.
Yep, the dream team.
Well, that's why I'm super proud to support this woman. Because she's got such a big vision. And she can't do it alone. None of us can do it alone. Right? That's the reality of it. And together we're so much stronger. When we collaborate, when we connect, when we show up with authenticity and vulnerability and are willing to just put ourselves out there, the failures, the successes, what went right, what went wrong, when we collaborate across different disciplines, that's how this change is going to happen. Mary's got a huge vision, like global UN table vision, right? That's what's going to happen. So it's super exciting that you guys are here for the ride. And I'm just like on our coattails. So, do you want to say something to that? And then I'm going to round up.
I think Mel has already said it. I can't do it without you guys. I really do believe 100% in the concept of a trauma-free hospital experience for hospitalized infants and families. And in doing that, we can also help ourselves, right? Fill our own cups up and be those. I'm coming back to the image from Paula Guerra with Mother Teresa and the drop into the ocean. It might feel like you're not doing much, but together, all of our contributions are going to change the face of the planet. And as Hemant mentioned, in doing that, we get to change the future. We get to impact future societies and improve the health and wellness of people. That's the legacy, right? People that will live beyond us. But we have to do it together. And I feel really honored that you guys were called to come here and share this experience with me. This is our 3rd conference. That's really awesome. Next year's our 4th. I want to see all of you guys there. And I want us to all stay connected with friends. Where is it? Where is it? Hold
on. So it is time to say goodbye. That time has come. But for some of you, maybe this doesn't feel like the end. Maybe this feels like the beginning. Maybe there's been a fire awakened in your belly, and the last 2 days have poured kerosene on that, have poured some fuel on that. Maybe you're tired of swimming upstream in the current, against the current. Maybe you're tired of being alone. You don't want to do this on your own anymore. And so for those of you who want to keep this going, for those of you who want to stay engaged and involved in this mission, Mary and I are having a little meet-up in the mezzanine in the hotel at 5:30. So Quantum Leapers,
the people who are on the current Quantum Leap program, people who have been on it before, for those who are interested, and the certification is just a chance to come and chat to us about that, with any questions that you might have, and also talk to people who are already experiencing it, okay? So that's just a real heartfelt invitation to you, for those of you who think, you know what, I really want to know more about getting more involved in this mission and being part of this journey. We'd love to see you there.
Edinburgh, Scotland. That's where. You've got your save the date. There might be some flexing on the date, but it'll definitely be in 2021. Okay? We'll definitely be there, okay? So stay tuned. I'll keep you posted. And thank you so very much. You've been an absolutely amazing group to play with, to work with, to chat with. It's been really a blessing.
So give yourselves a big round of applause.
Woo-hoo! So now we have the honor of our closing ceremony with the Vice President of the college is going to come up and say a few parting words. Please, big round of applause.
Thank you so much.
Oh my goodness, thank you. This has been amazing.
I know this since I arrived. Hello, everyone. I have some words written, but I'm not sure that it is what I want to say right now. When I came in, I noticed an excellent vibe, and I don't think it is written in my words. It is much more formal what I have written here. And it is interesting to see that in your talking, I found some of the ideas I had here. It is so good to have you with us. It is so good to have you in a country that is so small, but that is so old. We have a very, very solid culture. We have very good nurses. Sometimes we don't have the resources, and it was said here also since I came. But I believe that it is in our structure to have hope and to be courage. So I think our country is probably a very good host of your excellent job. I would like, of course, to say thank, and it's from my heart, and I also represent my school because I'm the vice president, and that's why I'm here. I would also like to thank everyone that worked so that this could be possible. And I would do it, thanking Mary, and with you, I thank all the team that comes with you, but also, of course, Alice, which is my colleague and friend for many years, and who is a woman that has the capability to bring together other people and the best that other people have when we must go on. And thank you, Alice, for that. This is not a very, very good period of the time. We are now facing a very new and challenging danger. Maybe this had some implication in your decision to come or not to come. I'm glad that you came, and I hope sincerely that you go back home full of health and, of course, much more richer. I noticed that already, that every one of you, and me even in the small period of time that I was here, that we take much more home that we brought when we arrived here. Thank you very much. It was a great honor to have you here.
I'm also Mary, but Maria José. And I belong to this team, of Lisbon team, and I was asked to present the posters, not the posters, I'm sorry, to present the gifts for the people that won the posters. I have to say that there was 3 of us that appreciated the posters, and it was hard because they were very, very good. Congratulations to all of you. So, we were not able to eliminate any because of quality, because they were not as good. It has to be our other ways of thinking. And so we went for those that translated better the theme of the conference, because they lead change and lead change in the environment, in the stress of the parents, and in the care that nurses are providing for their patients. So we gave out 4, we consider 4 as the best. 1 in English, and we cannot present you the gift from our institution because it is in English, and the gift is to buy books in Portuguese. So Mary was so kind to present the premium for the first one in English. And let me, I won't read this well, and I'm over the age, we don't use glasses. Leading for Change, Developing Neurodevelopment Care. We consider that it was exactly the theme, not only giving better care, but leading change. So congratulations to you. Come up. Mary, come up also. Yeah. Thank you for giving us for your poster. Thank you. And then Nurses' Knowledge About Oral Feeding by Ana Abrantes. And her study is about helping parents with oral feeding, and she is a PhD student, and she's also the future of our school because she's a teacher now here also. She's a nurse and a teacher. That's not why she was chosen. She was chosen because of the quality of the poster. Don't get me wrong. NICU Parental Stress Assessment Tool by Fátima Souza. Thank you for your poster also. And in 3rd place, the Impact of Development Care Program in NICU, Liliana Ferraz. So we have the United States represented here, Philadelphia, I believe. You're from Philadelphia? New York, yeah, okay. She's from the United States. She's from Coimbra, and the other nurses are from Lisbon, okay? There were a lot of very, very good literature reviews, but we chose one, but the others we chose researchers that were already concluded or at the final stage. So thank you for giving us so good posters, so much information about what you're doing and what you're researching. The posters are also in your ebook, if you want to go over. Now, this conference, I think we already finished, but they asked me to finish. So let me say two things. I need courage and hope to be here. Courage because it is impossible to say, to do a synthesis, a resume of what was done, because it was so good and so profound, and took us in a trip from the NICU to the future lives of the lives that these kids live, even have an adults. So I think it made us think how important our care is. But it also talked a lot about legacy. And I thought about my own experience that I had never thought. When I was a nursing student, and that was in the 80s, I went to NICU, and the development of NICUs in Portugal was later than in the States. So I did a week experience, and it was so terrible that I decided that I will never have anything to do with pediatrics or NICU, because the kids were very, very, very sick. The doctors only came once a week. The families could not come in, so they looked through the glass, or sometimes even not even that. And I don't think anybody knew what they're doing. They're doing their best. But I knew one thing: I will never be a nurse. So I said to my nursing teacher, I would rather clean floors than work in an INCU. And I went home, and my mother said, who was a nurse, I told her what I said, and she said, you failed nursing school. It's over for you. But no, she was a very good teacher, and she understood why I felt like this. So I did survive nursing school with success, and then I worked in adults, and one day I did my pediatrics. And when I did my pediatrics, I had to go into NICU. It was with a heavy heart, believe me. But you know, I went into a unit that was very much better than other units. And there was this head nurse, she retired, she's still alive, that had another approach, and she made the whole team that had another approach. And for many years, that team was so good with parents. I'm not saying that they're not anymore, but they were the best then. And one day I was in the meeting, in the nurses' shift change, and everybody were talking about how parents were. And she said, did you ever think how the mother thinks? And that changed the whole conversation and made me think how to focus and thinking what the mother is feeling, what the mother can think. And she left a legacy for the NICU nurses of Portugal, a legacy in my life, because I then loved NICU. It was nice, those kids, the way the nurses helped the mothers and helped the kids. So it did change, you know. Nurses can not only touch the student, not only touch the kid, connect with the kids, connect with the parents, but also connect with other nurses and help them change. Because many nurses change, and I changed. And I think today, as a teacher, so many times, and the way that nurse was, and it did leave a legacy for me. So today, when I was here and I heard about legacy, oh, sorry. And heard the new nurses talking how they were reflecting on what was said here. And many times you go to places and you hear about scientific results, and they were great scientific results here. But this mixture of hope, courage, of connections, and scientific results is so good for all of us. And it was good for me. So I think all of us, and especially the speakers today, left a legacy that will impact still us, but will impact the new nurses that are here sitting, or the student nurses that are sitting here. And for sure, they will be different because of what you did today. So I'm sorry, I know this is not the way you win a conference, but legacy is something that really connected with me, and I thank you all for this conference. Thank you.